Welcome back to the deep dive. Today, we're really honing in on the evidence base for carotid intervention. And look, this isn't just about ticking off papers, it's about, well, synthesizing that data at a true consultant level.
Exactly.
So if you're gearing up for those high-stakes vascular vivas, or maybe you just want the absolute core thinking behind the latest ESVS 2023 guidelines, this is definitely the deep dive for you.
That's the goal, isn't it? We're moving beyond just, reciting bullet points from a summary.
Right.
The mission here is to really understand why these trials matter, how sometimes they seem to conflict, and crucially, where the methodological nuances lie. It's about translating that foundational research into, well, immediate clinical judgment for your patients.
Excellent way to put it. Okay, we've picked 3 absolute titans papers or data sets that really define modern practice.
Yeah.
We've got GALA, tackling that perennial question of anesthesia choice.
Yep.
Then the NASCET synthesis, fundamental for who we treat and when. And finally, the CSTC meta-analysis, which really brings stenting and maybe most importantly, the timing of intervention into sharp focus. Right, let's dive straight in, metaphorically speaking, into the operating room with the GALA trial. So thinking back before GALA, this whole debate, it felt kind of relentless, didn't it? Why were surgeons, anesthetists, why was everyone so sort of polarized about choosing between local LRA and general anesthesia, GA, for carotid endarterectomy? What was the specific clinical controversy GALA was really powered up to resolve?
Well, the controversy, I think, was really rooted in perception versus hard data. Surgeons who preferred LRA often genuinely believed they were getting better outcomes.
Right.
And the core controversy GALA aimed to settle was exactly that. Does LRA or GA actually provide a superior rate in terms of the primary composite outcome, that being perioperative death, stroke, or MI? Historically, many units felt LRA was just inherently safer, maybe because of the monitoring, but we needed that robust randomized evidence.
Okay, and let's unpack that monitoring aspect. What exactly is the clinical advantage that the LRA proponents always cite? It always comes down to that real-time neurological assessment, doesn't it? But maybe spell that out for the trainee listening.
Yeah, it's considered the gold standard, really, for monitoring cerebral perfusion during clamping. I mean, think about it. The patient is awake, they're alert under LRA. If they suddenly become drowsy, confused, or, heaven forbid, develop a hemiparesis when you clamp, instantly. It's real-time feedback that brain perfusion has critically dropped, and you probably need to shunt.
You lose that completely with GA.
Completely. Under GA, you're forced to rely on, well, less precise surrogates, EEG, maybe transcranial Dopplers, stump pressures. None are as direct as asking the patient to squeeze your hand.
Right. Now, GALA was pretty groundbreaking, mainly because of its sheer scale. Can you tell us about the design and the numbers that made this study so definitive?
Yeah, GALA is still the largest single randomized controlled trial, the RCT, comparing these two techniques directly. They recruited 3,526 patients. That's a huge number.
Massive.
And that gave it the statistical power needed to detect even small but clinically meaningful differences. Or, as it actually turned out, to pretty definitively confirm equipoise between the two methods. The multi-center randomized design was key. It basically eliminated the selection bias that really plagued all the earlier, smaller studies.
And that bias point is critical, isn't it? Because you mentioned earlier, even before GALA landed, there was this massive meta-analysis. What was it? 25 observational studies, 6 small RCTs, over 150,000 patients.
That's the one.
And that did seem to suggest LRA was superior. So how did that pre-GALA observational data conflict with what GALA ultimately set out to test?
Well, that observational data on the surface looked incredibly compelling. It suggested LRA was associated with statistically, shorter operating time, significantly lower perioperative stroke. The odds ratio was about 0.76.
Impressive.
Fewer cardiac complications, OR 0.59, and even lower mortality, OR 0.72. I mean, it really looked like a slam dunk for LRA based on those big numbers.
So why wasn't it?
Because, and this is the crucial point for any consultant, for you listening, when the authors of that same meta-analysis pooled only the data from the few small RCTs that existed then, those statistical differences completely vanished. Gone. It strongly suggests the observational data suffered from selection bias. Surgeons were likely, and understandably, choosing LRA for their fitter, perhaps less complex patients, which would artificially lower the complication rates seen in that LRA group.
Okay, so GALA steps in, designed specifically to eliminate that bias through proper randomization, and it delivers the definitive answer on the big outcomes. What was the key finding regarding that primary composite outcome, perioperative death, stroke, or MI?
The headline finding was equipoise. Essentially, it demonstrated that neither technique was superior for preventing those major adverse events. The rate was 4.8% in the general anesthesia group versus 4.5% in the local regional anesthesia group.
Pretty close.
Very close. And the difference was not statistically significant. So no winner on the primary outcome.
But as always in medicine, the conversation rarely ends neatly there. There are always nuances.
Yeah.
Were there any specific subgroup analyses or perhaps other measurements focusing purely on, say, cerebral events that kept the LRA argument sort of simmering?
Yes, absolutely. And you need to look beyond just that JLA primary endpoint in an exam setting. First, if you look at pooled data from 5 of the big CEA versus CAS trials, it actually showed a reduced 30-day stroke death rate, specifically when the CEA was done under LRA. The adjusted relative risk was 0.70.
Interesting.
And second, maybe even more tellingly, some studies started looking at new ischemic brain lesions, NIBLs, using routine post-op MRI scans.
Is silent strokes.
Yeah, exactly. And those NIBLs were reported as being significantly more common with GA, about 17.1% compared to LRA, which was down at 6.7%.
Okay, so that NIBL data, it does suggest LRA might offer better cerebral protection at a kind of microscopic level, even if that difference didn't quite reach statistical significance for the big macroscopic stroke or death outcomes in JLA itself. That feels like an important point for a trainee to be able to articulate.
It absolutely is. It suggests LRA might be mitigating some of those small embolic events that don't necessarily result in a clinically obvious stroke but could still have long-term consequences. It certainly supports considering LRA if you're particularly worried about border zone perfusion in a specific patient.
Let's pivot slightly to complications. Thinking about JLA specifically, was there any evidence that the choice of anesthetic affected the rate of that most feared immediate post-op problem? A neck hematoma needing reoperation?
No, none at all. The risk was virtually identical and statistically insignificant. The incidence of hematoma needing a trip back to theater was 2.6% under GA versus 2.3% under LRA.
So no difference there.
No difference. Which kind of refutes any lingering argument that LRA patients might be more restless or somehow more prone to bleeding immediately postoperatively.
Okay. Now, moving away from purely clinical metrics for a second, the source material really highlights a non-clinical factor that strongly favored GA. This is all about the patient experience, isn't it?
Precisely. And honestly, this is probably what really informs that final guideline recommendation more than anything else, given the clinical equipoise. GALA showed this massive disparity in patient preference and satisfaction.
How big a disparity?
Huge. Only 65% of the LRA patients reported being highly satisfied with their experience, compared to 93% for the GA group.
Wow.
And even more crucially, when they asked them, if you had to have this again, would you choose the same method? 97% of the GA group said yes, versus only 61% of the LRA group. That patient perspective, especially when there's no major clinical outcome advantage for LRA, that was pretty decisive.
So, pulling it all together, GALA establishes clinical equipoise on the major outcomes, but patient preference leans heavily, overwhelmingly, towards GA. How does all that translate into the definitive ESVS 2023 guideline, Recommendation 65?
Right. Recommendation 65 is graded as Class 3A Level B. So an ISVM means should be considered, and Level B indicates it's based on high-quality evidence, mainly JLA. It states that the choice of anesthesia is ultimately at the discretion of the surgeon and the anesthetist.
Okay.
And importantly, it should factor in local experience, the surgeon's comfort level, and crucially, patient preference. GALA essentially provides the robust evidence base that allows for this clinical freedom and shared decision-making.
But let's think about the system for a moment. If a vascular unit is really focused on maximizing resource efficiency, are there other operational metrics, perhaps from non-GALA studies, that might still nudge them towards choosing LRA, even with the equivalent clinical outcome?
Oh, absolutely. This is where LRA might still have an edge, not on the big 3 outcomes, but on things that affect resource use and costs. Observational data, again with the caveat about potential bias, frequently reports LRA being associated with lower rates of things like cranial nerve injury.
Okay.
Also shorter overall operation times, shorter stays in ICU or HDU, reduced total length of hospital stay, fewer readmissions, even less postoperative pneumonia reported in some series. These factors can be quite compelling arguments for LRA, particularly in a resource-constrained healthcare system, provided, of course, the surgeon and the team are comfortable and experienced with it.
Right. Okay, let's wrap up JLA then. Imagine you're in the Viva. A trainee, maybe quite well read, but perhaps overly focused on those observational studies, starts arguing that LRA should be the standard because of that perceived reduced stroke risk. How do you provide that consultant-level rebuttal, bringing it back to GALA?
Okay, the key is to gently but firmly remind them about the selection bias inherent in that observational data. You have to state clearly, those apparent differences did not hold up when rigorously tested in the large, randomized controlled trial setting of GOA.
Emphasize the RCT.
Exactly. You acknowledge the theoretical benefit of continuous neurological monitoring under LRA. Maybe mention the interesting NIBL data as a nuanced point, but you must emphasize that based on the highest level of evidence we have, which is GALA, we have statistically confirmed equivalence in major outcomes: death, stroke, MI. And that equivalence is what allows us, ethically and clinically, to prioritize patient satisfaction and potentially operational efficiency, rather than feeling forced to use one method over the other based on flawed data.
Perfect. So give me your final punchy summary statement for the exam on the GALA trial and its clinical application.
Okay. In summary, the GALA trial demonstrated statistical equivalence in the crucial perioperative composite outcome of death, stroke, or MI between local and general anesthesia for carotid endarterectomy. I apply this high-level evidence by ensuring the anesthetic decision is a shared one involving the patient and the anesthetist. I might preferentially utilize LRA in specific complex cases where I feel continuous neurological assessment is particularly valuable, but overall, I recognize that the robust RCT data from GALA supports flexibility and patient choice, primarily because the major clinical outcomes are proven to be equivalent.
Okay, excellent. So GALA tells us how we might operate, but the NASCET and ECST trials, or rather their synthesis, really established who we operate on. Why is it absolutely essential for a vascular surgeon sitting their exams to understand the methodologies of both NASCET and ECST when discussing symptomatic carotid disease? What's that core methodological difference in how they measured stenosis?
This is absolutely fundamental, isn't it? You have to understand both because they essentially defined the threshold for intervention that we still use today. But, crucially, they used fundamentally different denominators for their measurements.
Right.
NASCET measured the stenosis percentage by comparing the narrowest point in the ICA lumen to the lumen diameter of the distal, presumably healthy, ICA. So the reference point is well beyond the plaque itself.
Okay.
ECST, on the other hand, compare that narrowest point against the estimated original diameter of the carotid bulb at the level of the stenosis. It's trying to reconstruct what the bulb should have looked like without the plaque.
Two different rulers, essentially.
Exactly. And because of that difference, their raw percentages just aren't directly comparable. A 70% ECST is not the same as a 70% NASCET.
Which can definitely be confusing. So how do those two different grading systems roughly map onto each other, particularly in that severe stenosis range where we know the clinical benefit is really concentrated?
Yeah, in that most severe and therefore most clinically relevant range, the systems do roughly align, thankfully. A stenosis that's graded as 70% up to 99% by the NASCET criteria corresponds approximately to 80% up to 99% using the ECST criteria.
Okay, so 70-99 NASCET is about 80-99 ECST.
Roughly, yes. And importantly, both trials, despite their different measurement methods, clearly demonstrated the maximum benefit for CEA in this specific high-grade group.
Now, individually, they were powerful, but we really needed a unified voice to move beyond just reciting trial acronyms. What specific entity, what collaboration pooled the symptomatic patient data from these two massive trials to generate those really high-powered conclusions on efficacy that now underpin our guidelines?
That crucial work was done by the Carotid Endarterectomy Trialists Collaboration, the CETC. They undertook a huge effort to perform a meta-analysis using the individual patient data from both trials.
Individual patient data, that's key.
Absolutely key. It allowed them to harmonize the endpoints and, crucially, pool the statistical power of both NASCET and ECS. This let them definitively assess outcomes across the different stenosis grades, and it's the CETC work that really forms the bedrock for those ESVS class recommendations for symptomatic disease.
Now, thinking about methodology again, the NASCET method, using that distal ICA as a reference, it has a recognized limitation, particularly when you're dealing with patients who have chronic near occlusion, or CNO, the so-called string sign. Why does the NASCET measurement sometimes fall down in these CNO patients?
Well, the limitation arises because in patients with these very severe near-total occlusions, the distal IC downstream from the stenosis often experiences collapse or significantly reduced filling simply due to the profound lack of flow getting through.
Makes sense.
So if you then use this collapsed spuriously small distal ICA diameter as your denominator, which the NASCET method mandates, you can end up artificially overestimating the true degree of stenosis. It might look like 99% when functionally it's less severe, or at least the morphology is different. In those tricky CNO cases, the guidelines sometimes suggest using the contralateral ICA diameter as the reference denominator, assuming that other vessel is relatively normal, to try and get a more accurate assessment.
Okay, let's get to the really critical outcome numbers, focusing on that key symptomatic group, the 70-99% NASCET, 80-99% ECST cohort. What was the absolutely staggering absolute risk reduction, the ARR, achieved by CEA compared to best medical therapy BMT at 5 years, according to that pooled CETC data?
The ARR for preventing an ipsilateral stroke or death at 5 years in this high-grade symptomatic group was 16.0%. 16%. Which is, frankly, profound for any surgical intervention. If you look at the raw numbers, the risk of stroke or death was about 28.2% in the BMT group, and CEA slashed that down to 12.2%. That 16% absolute reduction is really the number that justifies performing this procedure globally.
And when we translate the ARR into perhaps a more intuitive measure, one that really communicates the value of the procedure, what was the corresponding number needed to treat, the NNT, to prevent one stroke or death in that high-grade symptomatic group over 5 years?
The NNT was calculated to be just 6.
6.
6. You only need to perform CEA on 6 patients with high-grade symptomatic stenosis to prevent one major stroke or death within a 5-year period. For any vascular intervention, really any medical intervention, an NNT of 6 is incredibly favorable and strongly supports why this is a Class I Level A recommendation.
Now, the benefit wasn't just large, it was also highly time-dependent, wasn't it? What did the later reanalysis of these foundational trials, I'm thinking particularly of the Rothwell data, show about the critical necessity of performing CEA quickly after a patient presents with a stroke or TIA?
Yes, the urgency is absolutely paramount. The reanalysis powerfully showed that the risk of having a recurrent stroke is highest immediately after that index event in the first few days and weeks.
Right.
And they actually quantified this urgency beautifully. They showed that operating within 14 days, even if your procedure carried a hypothetical procedural risk as high as 10%, which is obviously way above the accepted standard.
Way above.
It still prevented more strokes at 5 years than if you waited for 4 weeks, and somehow managed to operate at a theoretically perfect but unrealistic 0% procedural risk. The clinical message is crystal clear. Delay is more dangerous than accepting a reasonable, audited procedural risk. Get on with it.
Okay, can you give me the specific risk ratio, the RR, for ipsilateral stroke conferred by CEA over BMT, specifically for those symptomatic 70-99% stenosis, looking over that 5-year time frame from the CETC data?
The relative risk, or RR, was 0.44.
0.4.
Yes, 0.44. And importantly, it had a tight 95% confidence interval, ranging from 0.34 up to 0.58. An RR well below 1.0 shows a benefit, and an RR of 0.44 demonstrates a really massive, statistically significant long-term protective benefit for CEA in this specific high-risk cohort.
Let's just briefly circle back to methodology in those tricky CNO patients. We know that in NASCET, there was quite a high crossover rate. About 29% of patients originally randomized to BMT ended up having CEA anyway, but were still analyzed in the BMT group. Why does using that standard intention to treat analysis in this specific context potentially lead to an underestimation of the true benefit of CEA in that CNO subgroup?
Right, because intention to treat, or ITT analysis, means you analyze patients based entirely on the group they were originally randomized to, irrespective of the treatment they actually received down the line. So if nearly a third of the patients officially designated as being the BMT group actually crossed over and received the active intervention, CEA, but their subsequent strokes, or lack thereof, are still counted against the BMT arm, well, it makes the BMT arm look better than it was, or conversely, it dilutes the apparent benefit of CEA. It likely led to an underestimation of just how effective CEA truly was for that very high-risk CNO group.
Makes sense. Now, to ensure that the benefits we've just discussed clearly outweigh the risks of the surgery itself, what was the established 30-day procedural risk threshold, the maximum acceptable rate of stroke or death for operating on symptomatic patients, set by these early trials and notably retained by ESVS in 2023?
That long-standing benchmark, the line in the sand, is that the combined 30-day risk of stroke or death following CEA in patients presenting with symptoms must be 6% or less.
6%.
6%. And the guidelines are very clear. If a unit or an individual surgeon is consistently operating above this threshold, the net long-term benefit of the procedure is effectively eroded, and frankly, they should probably stop operating on symptomatic patients until they can demonstrate improvement and meet that standard through audit.
And this powerful evidence obviously translates directly into the guidelines. What is the ESVS 2023 guideline recommendation class and level for performing CEA in these 70–99% symptomatic carotid stenosis patients?
Okay, that's recommendation 40 in the ESVS 2023 guidelines. It is graded Class I, Level A.
Top marks.
Absolutely. Class I means is recommended or should be done. Level A means it's based on multiple high-quality RCTs or meta-analyses, like the CETC data we've been discussing. It confirms that CEA is the undisputed standard of care for this specific group, always conditional on meeting that crucial 6% safety threshold.
Now, let's consider the other end of the spectrum, the challenging low-grade patient. They're definitely symptomatic, but their stenosis is measured at less than 50%. Yet, perhaps they continue to have recurrent TIAs despite being on optimal BMT. How do the ESVS guidelines navigate this quite rare and difficult scenario?
Yeah, this is tricky. So the general rule is clear. For stenosis 50%, intervention is not recommended. That's recommendation 52, Class 3, Level A, meaning it's proven not to be beneficial or potentially harmful.
Okay, so usually no.
Usually no. However, recommendation 53 provides a very narrow exception. It's graded Class II, Level C. Class I means may be considered, and Level C means it's based on consensus opinion or small studies, not strong RCT data. This allows CEA, or potentially CAS, to be considered, but only in highly selected patients who are having genuinely recurrent TIAs or minor strokes, despite documented optimal BMT.
And crucial.
Crucially, only after a really detailed neurovascular workup has excluded other potential embolic sources, checking for AF, cardiac shunts, other vascular issues, and the decision has to be ratified by a formal multidisciplinary team review. This is really reserved for the extremely rare patient where the carotid plaque, even though it looks mild on imaging, is strongly suspected by the MDT to be the culprit after everything else is ruled out. It's a consensus approach, not evidence-based in the same way.
Okay, final clinical vignette for this section then. You have a patient, they've got a 75% NASCET stenosis, clearly high grade, but their index event, a minor stroke, actually happened 5 months ago. They are now on fully maximized best medical therapy. Has the urgency window completely closed by this point, or would you still recommend offering them CEA based on the evidence we've discussed?
Oh, I would still strongly recommend CEA for that patient, absolutely. While we know the benefit is greatest and the urgency is highest within the first 14 days, the proven long-term benefit, remember that 16.0% absolute risk reduction at 5 years, extends significantly beyond that acute window. The data supports benefit for intervention up to 6 months after the symptom onset.
So 5 months is still well within that window.
Yes. As long as the patient remains a reasonable surgical candidate and their perioperative risk is acceptable within that 6% threshold, they still stand to gain substantial long-term protection from stroke by intervening at 5 months. Delaying much beyond 6 months, however, does seem to significantly attenuate that long-term gain, according to the trial data.
Excellent. Right, give me your final integrated summary statement on the ECST-NASCET evidence synthesis and its direct clinical application for the exam.
Okay. In summary, the synthesis of the ECST and NASCET data, primarily conducted through the CETC meta-analysis, definitively established that CEA offers a massive long-term protection against stroke and death in patients with high-grade, 70–99%, symptomatic carotid stenosis. This was quantified by an absolute risk reduction of 16.0% and a highly favorable number needed to treat of just 6 at 5 years. This powerful evidence mandates 2 critical clinical actions in my practice. First, absolute adherence to the 6% or less 30-day procedural risk threshold for stroke or death, verified by continuous audit. Second, prioritizing rapid intervention, ideally within 14 days of symptom onset, while still acknowledging that the window of benefit extends up to 6 months. I apply this evidence by ensuring all eligible high-grade symptomatic patients are fast-tracked for surgery and that our unit's performance consistently meets that crucial 6% safety standard.
Great. We've firmly established the strong evidence base for CEA in symptomatic patients. Now, let's introduce the main alternative, carotid artery stenting, or CAS. We already had those 4 big head-to-head trials, CREST, ICS, SPACE, EVA3S. Why then was the carotid stent trialists' collaboration, the CSTC meta-analysis, considered necessary? What extra value did pooling that data bring?
Well, while those individual trials were landmark studies, they often lacked the sheer statistical power to definitively resolve differences in specific important subgroups.
The subgroup issue again.
Exactly. Think about things like patients treated very early versus slightly later, or maybe older versus younger patients, men versus women. Individual trials might show trends, but not statistical certainty. CSTC pulled all the individual patient data from those 4 major RCTs. We're talking over 4,700 symptomatic patients in total.
Huge data set.
Massive. And this allowed them to harmonize the endpoint definitions across the trials, significantly increase the statistical power, and perform those critical, detailed subgroup analyses, particularly looking at outcomes stratified by the timing from symptom onset. And it's those analyses that really dictate our current, quite specific timing recommendations regarding CEA versus CAS.
Okay, so looking at the big picture first, the overall non-stratified pool data from CSTC, what was the key 30-day outcome difference found between transfemoral CAS, TFCAS, the standard approach in those trials, and CEA when treating symptomatic patients?
The key finding looking overall was a higher procedural risk associated with CAS. Pooling the data showed that TFCAS incurred significantly higher rates of the composite endpoint of 30-day death or stroke. The numbers were about 8.7% for CAS versus 5.5% for CEA.
Okay, so a clear difference favoring CEA on stroke death.
Yes. And if you looked at the combined outcome of death, stroke, or MI, the odds ratio was calculated at 1.60, which clearly favors CEA being safer overall in that crucial first 30 days.
But as we know, there's often a trade-off in medicine. What was the one major 30-day adverse event where CAS consistently came out looking better than CEA in this pooled data? The clear advantage, if you like, for the less invasive approach.
That's the myocardial infarction rate, MI. The pooled data consistently show that CAS was associated with statistically lower rates of 30-day MI compared to CEA. The odds ratio here was 0.51, clearly favoring CAS.
Right.
And that really highlights the core risk-benefit balance, doesn't it? CAS appears to reduce the immediate cardiac risk associated with open surgery, while CEA reduces the immediate neurological risk. Generally, in carotid disease, we tend to weight the prevention of stroke more heavily than the prevention of MI because stroke often has far more devastating and permanent long-term consequences.
Makes sense. Now, the CSTC's really unique contribution was drilling down into the timing. What were those critical, very early time windows they specifically assessed? And why are these first few days post-symptom considered so clinically volatile or risky?
They focus specifically on 2 key early windows. The ultra-early window, defined as intervention at $27 days from symptom onset, and the subacute window from 8 to 14 days.
Oh, okay.
These periods are considered particularly volatile for a couple of reasons. Firstly, the plaque that caused the initial TIA or stroke is thought to be highly unstable immediately after the event, making it more prone to shedding further emboli during any manipulation, whether surgical or endovascular. Secondly, if the patient has already sustained an established ischemic stroke, intervening too early carries a theoretical, though perhaps overstated, risk of converting that ischemic injury into a hemorrhagic stroke, particularly with reperfusion. So it's this tightrope walk between the high natural risk of recurrent stroke if you wait and the potentially increased procedural risk if you intervene too soon, especially with certain techniques.
Right. Let's nail down the absolutely critical numbers from CSTC regarding that ultra-early window, the first 7 days. When they compared transfemoral CAS versus CEA performed within that first week, what were the actual 30-day stroke death rates for each, and which intervention came out looking dramatically less safe?
Okay, in this urgent $7-day group, TFCAS was shown to be statistically and, frankly, dramatically less safe. The 30-day stroke or death rate for patients undergoing CEA in this early window was impressively low, recorded at only 1.3%.
1.3% for early CEA.
Yes, very safe. However, the rate for patients undergoing TFCAS in that same first week just exploded upwards to 8.3%.
8.3, that's a huge difference.
It's enormous. It provides really strong confirmation that this acute phase, the first 7 days, is a uniquely dangerous time for transfemoral endovascular manipulation of an unstable symptomatic carotid plaque.
Okay, 8.2% versus 1.3%. Just to hammer that home for the exam, what was the specific relative risk, the RR, calculated by CSTC when comparing TFCAS versus CEA for interventions performed within that first 7 days?
The calculated relative risk for death or stroke was 6.7.
This is 0.7.
Yes, 6.7, favoring CEA being safer. Although the confidence interval was quite wide, reflecting fewer numbers in this specific subgroup, it ranged from 2.1 up to 21.9. But that point estimate, an RR of 6.7, is arguably the single most compelling piece of data we have, arguing strongly against routine transfemoral stenting in the acute symptomatic phase. It tells you, based on the best available evidence, that TFCAS is nearly 7 times riskier than CEA in that first week.
A truly dangerous statistic for early TFCAS. Did this significantly increased risk profile for CAS persist when interventions were delayed just slightly into that 8 to 14-day time window?
Yes, it did persist, although the magnitude of the difference reduced somewhat. The risk was attenuated but remained statistically significant. In that 8 to 14-day window, patients undergoing TFCAS still had a worryingly high 30-day death or stroke rate of 8.1%.
Still,
Still very high. Compare that with the rate after CEA in the same 8-14-day window, which is 3.4%. This resulted in an odds ratio of 2.42, again still strongly favoring CEA as the safer option, even into the second week after symptoms. The guidelines really reflect this unequivocally. If you feel you must intervene early, within 14 days, for a symptomatic patient, CEA is demonstrably the safer choice based on this high-level pooled RCT data.
now, technology evolves. Since those landmark RCTs like CREST and ICSS were conducted, we've seen the development and increasing use of transcarotid artery revascularization, or TCAR. Does the source material, the ESVS guidelines relying on CSTC, give us enough robust timing data yet to confidently say how TCAR's safety profile stacks up against CEA, specifically in that critical acute window?
No, not really, not yet. TCAR is definitely promising, conceptually. It avoids manipulating the aortic arch, which is a source of emboli in TFCS, and it uses proximal flow reversal during stenting, which should theoretically protect the brain better. However, the guidelines note that currently only one registry study has actually reported TCAR outcomes specifically stratified by the delay from symptom onset to the intervention. So we simply lack the high-level, level A or B evidence from RCTs or large, well-conducted comparative studies to confidently compare TCR's early safety profile directly against the proven low-risk profile of early CEA, that 1.3% rate in the first 14 days. It's an area of intense interest in ongoing research, but the robust comparative timing data just isn't there yet for TCR.
Okay, that's an important point. Let's just revisit that overall safety threshold for a moment. The ESVS 2023 Guideline Writing Committee made a conscious decision to retain the established 6% maximum 30-day death stroke risk threshold for symptomatic CEA. Why did they resist the temptation to lower this target, perhaps to 4 or 5%, given that many modern series actually report better results than 6%?
Yeah, this was apparently quite a deliberate strategic decision aimed primarily at combating potential risk aversion among clinicians.
Risk aversion, how so?
Well, the Guideline Committee expressed concern that setting an excessively low, perhaps overly aggressive threshold, say, mandating less than 4%, might inadvertently encourage surgeons or interventionists to delay intervening on patients, especially within that critical first 14-day window. They might be tempted to cherry-pick only the absolute lowest risk patients or wait longer just to ensure their audited results look good against a very tough target.
Gaming the system, potentially.
Potentially, or just becoming overly cautious. And given that we know the risk of recurrent stroke is highest early on, any such delay caused by chasing an ultra-low target could actually be detrimental to overall patient outcomes at a population level. So they decided to retain the established 6% threshold as a reasonable balance, ensuring that the primary focus remains on providing timely intervention, particularly urgency, rather than getting bogged down in achieving marginal reductions in procedural risk at the expense of speed.
Okay, that's a very interesting rationale. Now, speaking of procedural risk with stenting, what specific anatomical factors or perhaps procedural factors reviewed by ESVS are known to be associated with the higher risk of stroke, specifically after CSTC? In other words, who is likely a poor candidate for stenting based on pre-procedural assessment?
Yes, the guidelines highlight several factors that should flag a patient as being potentially high risk for CAS, particularly TFCAS. Anatomically, you need to look out for unfavorable aortic arch anatomy, things like a type 2 or particularly a type 3 arch, which often require more complex and prolonged catheter manipulation to access the carotid artery, increasing embolic risk.
Okay.
Also, severe calcification within the plaque or the vessel wall, very long or sequential stenosis rather than a single focal one, and a sharp angle of the ICA origin, say 60 degrees, can all make accurate stent placement more difficult and risky.
And
Clinically, the two big ones identified are patient age, specifically being over 70 years old, is consistently associated with higher CAS risk in the trials, and as we've just discussed extensively, attempting TSCAS very early, less than 7 days after a TIA or stroke, dramatically increases that procedural risk profile. These are the patients where you'd strongly favor CEA.
So pulling that timing data together based entirely on the CSTC's timing analysis, What is the clear, unambiguous guideline preference for the modality of intervention when you're treating symptomatic patients within that critical first 7 to 14 days after their event?
The guideline preference is strongly, unequivocally for CEA over transfemoral CAS, TFCS. This is recommendation 42 in the guidelines.
Recommendation 42.
Yes. And it's driven directly by that documented multifold increase in procedural stroke or death risk. Remember the RR of 6.7 in the first week for TFCAs performed in the acute phase. That data makes CEA the clear safest choice if you need rapid revascularization within 2 weeks of symptoms.
Okay. We've established the ESVS uses the 30-day 6% threshold. Now, some other guidelines, notably the German-Austrian and perhaps the ESO guidelines, tried to simplify this by suggesting an in-hospital death stroke rate target of a $4%. Why did the ESVS Guideline Writing Committee specifically reject using that shorter in-hospital window and stick firmly with the full 30-day standard for auditing outcomes?
They rejected the in-hospital window primarily because it risks masking a significant proportion of relevant complications. They cited RCT data showing that a substantial number of perioperative events specifically, somewhere between 19% and 24% of all strokes and deaths occurring within the first month, actually happen after the patient has been discharged, typically after day 8 post-op.
Right, so they'd be missed by an in-hospital only count.
Exactly. If you only audit the events that happen while the patient is still an inpatient, you could miss nearly a quarter of the total procedural morbidity and mortality. Therefore, the ESVS committee felt strongly that the full 30-day window remains essential to accurately capture all the relevant early procedural risks associated with either CEA or CAS, giving a truer picture of safety.
Okay, final complex clinical vignette for this section. You are asked to treat a 72-year-old patient, definitely symptomatic, presenting 6 days after a TIA. They have a severe carotid stenosis suitable for either treatment. However, their preoperative MRI brain scan shows a high ARWMC score, that's the age-related white matter change score documented as 8. How does this high imaging score specifically influence your choice of intervention modality in this acute setting?
Okay, that high ARWMC score is a major factor, tipping the scales heavily against the AS, especially given the acute timing. An ARWMC score of 7 or higher has been independently linked in studies reviewed by the guidelines to a statistically significantly higher rate of perioperative stroke, specifically after CAS compared to CEA. The hazard ratio reported is around 2.98, nearly a 3-fold increased risk of stroke with CAS in patients with severe white matter disease.
So combine the timing and the score.
Exactly. You're combining 2 major risk factors for poor outcome with CAS. First, the acute timing window. Patient is a $7 days post-event, where TFCS carries that RR of 6.7 for stroke death compared to CEA. And second, the high ARWMC score, which carries an HR of nearly 3 for stroke post-CAS versus CEA. Putting those together, the evidence overwhelmingly mandates that you should choose CEA as the only responsible and evidence-based revascularization method for this particular patient. CAS would be associated with an unacceptably high neurological risk.
Very clear. Okay, please give me your final integrated summary statement on the CSTC pooled analysis data, focusing on timing and its crucial clinical application for the exam.
Right. In summary, the Carotid Stent Trialist Collaboration, CSTC, pooled analysis rigorously quantified the inherent procedural risk of transfemoral CAS in symptomatic patients, confirming it carries a higher risk of 30-day stroke or death compared to CEA overall. Crucially, it demonstrated that this risk is catastrophically amplified up to a relative risk of 6.7 if TFCAS is performed within the first 7 days of symptom onset. I apply this high-level evidence in my practice by ensuring that CA is the primary and strongly preferred modality for nearly all symptomatic patients presenting within the critical 2-week post-symptom window. Transfemoral CAS is generally reserved for intervention performed later, or only considered acutely if the patient has specific, genuinely insurmountable contraindications or risks for CEO, such as severe neck fibrosis from previous surgery or radiation. And throughout, I ensure strict adherence to auditing our outcomes against that crucial 6% or less 30-day safety standard for all carotid interventions. #tag outro. Okay, we have really covered the waterfront there, meticulously dissecting the 3 absolute cornerstones of the evidence base for carotid intervention. We started with GALA, didn't we? Which ultimately provided that comforting clinical equipoise, empowering shared decision-making and patient choice when it comes to anesthesia.
Yeah, took that debate off the table to some extent.
Then we moved to the truly foundational NASCET and ECST data synthesis, the CETC work, which gave us not only the definitive proof of long-term benefit for CEA in high-grade symptomatic disease, that stunning 16.0% ARR,
And the NNT of 6?
and the NNT of 6, but also hammered home the critical mandate for rapid intervention, ideally within 2 weeks.
And crucially, we finished by synthesizing the CSTC data, which really provides the essential modern context for choosing between CEA and CAS. It confirms that while open surgery, CEA, carries perhaps a slightly higher risk of perioperative MI. The trade-off. It's a proven superiority in preventing major neurological events, stroke or death, especially in that dangerous acute time window, starkly illustrated by that terrifying RR of 6.7 for early TFCAS, makes CEA the default preferred revascularization technique for most symptomatic disease presenting early. And I think, understanding these core numbers, the ARRs, the NNTs, the RRs, but also understanding the underlying methodological issues like why observational data can mislead compared to RCTs, or why auditing over 30 days is vital. That is the essential difference between simply knowing the guidelines as a trainee and truly understanding and applying the evidence as a consultant.
Absolutely well said. Now, before we wrap up this deep dive, here's one final provocative thought for you, the listener, to mull over. It ties back neatly into the ESVS guidelines and the fact that evidence is always evolving. The ESVS 2023 Guideline Committee, as we heard, only managed to settle the debate on whether to intervene immediately for asymptomatic patients with very tight 80-99% stenosis, with quite a narrow 11-3 majority vote against routine immediate intervention.
It was contentious.
It was contentious, and partly they were relying on older asymptomatic RCTs, where the best medical therapy used back then was frankly suboptimal by today's standards. So the provocative thought is this. As we now eagerly await the results of major ongoing trials like CREST-2 and ACST2, which are specifically designed to compare modern intervention, CEA or CAS, against contemporary, truly maximized BMT, how might those new results potentially shift the calculus? Could they perhaps identify a new, very high-risk asymptomatic subgroup where the risk on modern BMT alone is so high that intervention does become mandatory again? That debate is definitely coming down the track, and it just reminds us that even our highest level evidence today is always subject to further scrutiny and refinement tomorrow.